Good evening, I'm Maureen O'Neil. Canadians love Medicare too much. Twice as much as hockey, 3 times as much as the Queen, although the new engagement may change that. Tommy Douglas tops the charts as the greatest Canadian because of his conviction and political courage in removing income as a barrier to health care. Canadians look south and have a sigh of relief and feel pious that we don't have millions of our citizens with no health care coverage at all. Our love of Medicare, its status as an icon in our national mythology, is a barrier to making necessary improvements. Its status as an icon has frozen in time how we organize services, who actually provides care, and which services are covered. Compared to other developed countries, we are ranked close to the bottom, right at the bottom, in the time it takes to schedule an appointment with a specialist. Why is it so hard to change? Let us step back to the late 50s when the CCF government, led by Tommy Douglas, was designing a new health system. Saskatchewan wanted good connections between GPs and specialists with public health and social services. There was even talk of community boards to ensure patient and community involvement and feedback. Unfortunately, an election was coming. Many doctors were already opposed. Given this opposition, Tommy Douglas's cabinet were worried that this fundamental reform would be lost if they tried to sell the whole new approach. Instead, cabinet agreed government would insure everybody so that people didn't have to pay for doctors' visits. Hospitals were already covered. Left aside was the dream of creating an unbroken continuum of care. They settled for a payment system, not the well-connected system of health that they wanted. This dramatic backdown did not save the day. Doctors went on strike anyway. The strike was settled by government agreeing to leave management of health care in the doctor's hands. This compromise did mean that people's incomes were no longer a barrier to doctors' care. However, there was no coverage of dentists, physiotherapists, psychologists, drugs, glasses. When the federal government brought in Medicare in 1966, all provinces eventually adopted the Saskatchewan Compromise. Private insurance through employers, particularly large employers, looked after care not covered by Medicare. Unfortunately, at least 30% of Canadians don't, and did not at the time and don't now, have those benefits. They must pay for these health services and drugs, not much different than America. However, it is much different than European countries. This is the main reason why we fare so badly in international comparisons. It's not what we have, it's what we don't have. It isn't efficient or even the most appropriate care to have only hospitals and doctors' visits fully funded. It's inefficient not to cover drugs, to have patchy access to affordable home care and nursing homes, to make it hard for people to see a psychologist or a physiotherapist. And it's definitely not good care when people with mental health or addiction problems have to wait months for treatment unless there is a dramatic crisis. I said at the beginning that it's possible, indeed even probable, that because Medicare is our #1 love, tampering with it exacts a huge political price. With the exception of our former health minister, the Honourable Jane Philpott, most ministers are reticent about saying to their voters that we have problems, that we could do much better, that there's lots of room for innovation and improvement. Staying the same, with at least 40% of every province's budget spent on health care, means we will be starving income support, education, housing, social services, the very kinds of supports that are important for good health. Curiously, there is a little discussion of why our health care is so much less safe, for example, than the Dutch. Provinces have tried to improve healthcare by creating regional management structures like the local health integration networks in Ontario, through various financial incentive payments to doctors, joining with the Canadian Institutes of Health Research in supporting patient-oriented research. We have had limited success in improving performance. We are still near the bottom of the charts. The definition of medically necessary to encompass non-doctor, non-hospital services remains unchanged. Too frequently, there are standoffs between a province and their doctors, as we see in Ontario. The technology revolution, and we'll hear lots about that tonight, has huge potential to give more control to us as citizens and patients to manage our own health. Is anybody here becoming an obsessive step counter? The sky is almost the limit. We see it in action in post-operative follow-up, as the Ottawa Heart Institute has been doing. But email appointments with your GP? Not usually. Any innovation you can think of, and you're going to hear about lots of them tonight, any innovation you can think of is happening somewhere in the world. We need to not only create them in Canada, but bring them home to Canada, try them out. Change regulations to accommodate. Ottawa doctors, Claire Liddy and Aaron Keeley, they developed an e-consult service which dramatically speeds the connection between family doctors' access to specialist advice. And what that means is that it turns out that with the exception of about 25% of cases, the GP can actually handle it. This can be hugely important for people in rural areas. My organization helps healthcare organizations and hospitals spread and scale better ways of doing things. So that means that examples like Dr. Liddy's and Dr. Keeley's get spread across the country. So what do I recommend for our much-loved but underperforming Medicare? Make it easy for one province to learn from another. Support, through regular health budgets, the best local ideas of doctors, nurses, and other healthcare providers who are encouraging positive change. Put expansion of the coverage of health services on the political agenda. Dare to experiment with both private and not-for-profit providers as long as patients don't have to pay. Put patients and families at the center, which brings it back to us. No more unconditional love. We should have the quality of care that Tommy Douglas fought for. After almost 60 years, isn't it time?